Hello, my name is Dr. Piyanat Priyanon, an interventional cardiologist from Perfect Heart Institute here from Bangkok. With me, I have Dr. Michel Le May. Dr. Michel, hi.
Hi, I'm from Ottawa, Canada. I'm at the University of Ottawa Heart Institute. I'm also an interventional cardiologist.
And welcome to Lumen Global 2014 in Bangkok. And I will ask you how you finding for the venue or the city.
So I got here just this morning after a long flight from Ottawa through Montreal and then Doha. So when I got here, I think that the first thing that I noticed is that it was a very big airport, and we are on the left side of this road instead of on the right side of the road. And I think that that's the way it is in Thailand.
You drive in different sides.
Different style. And I was looking for some of the temples as I was driving to the hotel here. And I remember very well, and I mentioned this at the conference earlier, in 1967 there was a very large collaborative effort to put pavilions at an expo in Canada, in Montreal. And the nicest pavilion at that time was that one that was the one from Thailand. People loved to have their pictures taken by that pavilion.
That might be the Grand Palace.
It must have been.
You have to take a chance to go visit there.
Okay. And so when I was driving here, I saw a few temples but I haven't had a good chance to explore the city yet. So they took me directly to the hotel here, and the hospitality from the group here, from the Lumen faculty with Samir Metad, has been really fabulous.
So you should spend a few days here in Bangkok to explore.
I plan to do so.
All right, okay, sir. So you're probably one of the longest Lumen faculty members. So how has the meeting evolved in the last several years?
Well, the meeting, I came at the time when the meeting was evolving towards a STEMI meeting, and this was taking place in Miami, and Samir invited me to come and present in Miami. And then I think that, the message that we were trying to give at the time was that it was important to try to get the time down for reperfusion, that we had to develop logistical ways of getting hospitals and regions organized in a way that they can develop STEMI systems. And so I think that the message has got out pretty clear in North America. And I think Samir had a vision at the time that we should take our message out on a global basis. And this is where Global Lumen started. And the first of these meetings took place in Dubai, and the next meeting after that was in New Delhi.
And what is the best advice you can give to the centers that are trying to develop their own STEMI programs?
I think that one of the things to do is to try to get all those stakeholders together. What we did is we started with basically going back over the evidence that time is of essence, and that primary angioplasty is better than fibrolytic therapy. At the time that we started, it was sort of like pell-mell. It was some gave lytics, some people did primary PCI. It was very, very disorganized. And we thought it was very important that we get it organized. And everybody was talking about how you get it organized, but nobody was doing it. So we decided to get everybody in a room and talk about the basic science. Let's look at the evidence. And once everybody was on the same page that it was important that we develop a system, we identified the stakeholders. So you need to identify, for example, who works in the emergency room. You need to identify the coordinators, the cath lab directors. You need to identify the EMS, because EMS plays a critical role. So once you've got all these stakeholders in one room, you can start thinking of the logistics of how you organize your STEMI system. And every STEMI system is a bit different. You've got to do what's right for your region, because you can't necessarily copy another system, because it may not work for you. You got to go and look at different systems and import what's best for your own region, put it together, and then you improve your outcomes.
And what is your view of performing PCI to the non-culprit lesion in a setting of acute MI?
Well, I think you're referring to the PREMI study, aren't you? The one that was just published in the New England Journal. And I think that, I think a lot, that has been probably the topic of many journal clubs. I think that a lot of, it's been very, very controversial. In our own practice, we don't do that. We don't do that because we still think that we need a bigger trial. I think the trial was relatively small. And I think that what we've been doing all along is we've been staging the patient so that if there's a high-grade lesion in a other vessel, then we'll bring the patient back a few days later. What we've noticed is that it's very, very, very rare to have a patient have an infarct from the non-culprit vessel within a couple of days. We talk about simultaneous infarcts at times. Those are rare events. They can happen, but they don't usually happen. So we feel that we should wait a few days and bring the patient back. And I think in a very, you can think of yourself in a 24/7 practice where you're during the weekend, you've got only one team, and if there's another patient that comes behind, suddenly now you're struggling with another vessel. That other vessel, it may sound simple to do, but you may run into problems with a dissection, or you may have to add more stents, more so than you thought, so your guider may not fit properly. It may not be as easy as one would think. The other thing that they did in primary is they include a lot of people with 50% lesions, which we tend not to do so. So I think that there are some other trials that are being designed now that will be enrolling very large volumes of patients. A little bit, if you remember TAPIS, the study that looked at the aspiration catheter, in that trial, there was a 1% mortality benefit for the patient, but when they did the big TASTE trial, that mortality evaporated. So I think we have to be very careful in interpreting the results of PRAMI.
Is there any exceptional situations that you do PCI to the non-culprit lesion?
So there are times, and I can remember one case just recently where we couldn't tell which was the culprit vessel. It was a circumflex or a right coronary artery. We knew the patient had an inferior wall infarction, and both vessels had TIMI3 flow in them. And you couldn't tell, like there was not any suggestion that there was a clot present in the vessel. There was not an ulcerated plaque. There was just two high-grade lesions, one in the circumflex and one in the right. And the lesion in the circumflex was like a third marginal where it ran kind of along the inferior wall. So we weren't sure, so we dilated both vessels at that time. There are people that will take on cardiogenic shock, for example. They feel that in the setting of cardiogenic shock that you try to revascularize as much as possible. And I think that you have to be there to know what you're going to do with that particular patient, because there are times when if you're struggling with the first lesion and you've used a lot of contrast, then moving on to a second lesion in the patient cardiogenic shock, if you're using excessive amount of contrast, you could potentially get that patient in more trouble. So sometimes you have to back off.
Well, thank you so much, Dr. Le May, for joining us today.
Thank you very much for having me here.